I feel pretty.
Okay, so we're going to start with essentially a review of CAD. So here I wrote in a definition for you guys. It consists of stable angina and acute coronary syndrome. And acute coronary syndrome consists of unstable angina and myocardial infarction. In general, your CAD is associated with ischemia to the heart, and potential infarction once you get to that ACS. Um, And there are multiple risk factors, but what is like your number one risk factor when it comes to like what is causing this ischemia? What is causing this like inguinal pain, blockage? It's gonna be your atherosclerosis. So that's the
Wait,
buildup of your plaque into the and related to metabolic syndrome, obesity, all of those things that can the big three. It's always gonna be hypertension, like hypertension, obesity, diabetes, hyperlipidemia. So I'm sure, yeah, smoking can be like, all these things that end up increasing your risk of heart disease, increase your risk of CAD.
Dad.
Uh, and this can be it's going to be a progression, slow progression. Your atherosclerosis, something that builds up over time. That plaque doesn't immediately cause blockage over time. It starts building up slowly and slowly and slowly, making that vessel tighter and harder for the blood to go through. And you can have the blood can have a harder time making its way through, which is where you have that heart ischemia. And when you're having a lack of blood flow, lack of perfusion, it's a painful feeling. And that's where your angina pain can come in. So here I have this little table. I think this is also just taken straight from the PowerPoint. But it's very helpful for kind of getting an understanding and telling compare and contrasting everything. Just keep in mind, again, you don't have to like fully hard commit every little tiny little piece. Um, just kind of get the general idea, general progression. So with chronic stable angina, this is something that's going to be P for palliative. How did it start? Like what's causing it? This is something that can be precipitated by exercise, stress, and resting is going to be something that improves it. Medication can improve it. So that's where your well, what medication is typical for inguinal pain? Yeah,
Nitro.
nitroglycerin. That zero point 0.4, is it microgram? I think it's microgram. Or is it milligram? Ooh, look,
Oh
I
no. I was like, I'm pretty sure it's milligram.
think it's milligram. Yeah. 0.4 milligram sublingual. Make sure they don't swallow. Keep it under the tongue, let it melt under the tongue.
Crunchy.
Yeah. So what are you looking out for after you give that nitroglycerin, and how often can you give it?
I like the idea of hypertension.
Yes. Yeah, I think it can make your blood pressure dip
Oh, darn
a good
straight.
chunk. Very good chunky. Yes, exactly. So yeah, you can give that every 5 minutes up to a maximum dose of 3 times. What happens if you have a patient, they were stressed out, they were doing some sort of stressful maneuver, exercise, whatever, and they have this chest pain. They know that they have coronary arterial disease. They have a prescribed nitroglycerin. They take their 3 pills in the appropriate amount of time. It still doesn't go away. They're already at rest. What do we start thinking about after that? Awesome. Yeah,
910.
perfect. So that's kind of like that general progression, that general idea that you guys need to take into account when it comes to the thought process behind angina pain and start thinking about, yeah. Start thinking about what would happen to the patient. What's the next step? So these are the things that you want to start thinking about. So again, some of these things might not be directly gone over during class or lecture. So maybe this is something where you can maybe reference the book, see what all the appropriate interventions are, or maybe watch a little video or something to add on if I think that like to help you kind of understand that progression for the patient. But when it comes to that ischemia, it's like a tightness, pressure, squeezing pain. I hear patients saying that it feels like an elephant's on my chest. That type of intense pressure that causes that pain. Yeah.
Tingle.
So additionally, R for radiation. That pain can radiate to the arm, the jaw, the shoulders, or the back. So I'm sure when you guys went over, it can go through whatever. Like I think you guys might remember when you guys did questions with Miss Brooks on delegation prioritization. There might have been one where like the patient has, I think back pain, and that was referring to like I think they call it like a not a back MI. What's the proper term? Like a posterior MI.
Agree.
So different radiating types of pain. Yeah, it's not a typical symptom, and women have other potential symptoms as well. So maybe can you guys list any that you guys can think about when it comes to atypical typical symptoms for like women? Yeah. What about some for like women specific things that um you might have? Yeah, so like nausea, indigestion, abdominal pain. Maybe also some, I think it already says jaw here. Jaw, maybe even, I think teeth pain can happen as well.
Mainly just jaw, because you
Yeah,
have like a big old vessel going in, well, going up in that direction. Um, so women might feel definitely indigestion, maybe some kind of shoulder pain. Um, I believe John women was more particular, but I could be wrong.
I believe so. I think particularly more in women. Maybe not women specific, but more prominent, maybe. Yeah.
There
But,
was something
uh,
that I was trying to look up right now. Um, when to call 911 after nitro.
mhm.
Because I was sitting here and I was thinking about it, because I saw an answer that was, like, after the first one, and then I was like, "Wait, I thought it was after 3," so I was looking it up, and apparently it's up in the air, so I'm not entirely sure what was told to you guys in lecture, but whatever was told to you in lecture, please follow that. 'Cause I find 2 different answers. I see some that are, um after the first dose, if after 5 minutes it doesn't go away, call 911, and then I see in other sources after the 3 doses, then call 911. So I'm not sure what exactly was told to you guys in class, because our notes don't even have it. Yeah, definitely ask that. That is something that is important, you know, some education that they need. When do you call 911? When do we have a genuine problem? When is this okay, now we're into unstable, we're into ACS and now possible heart attack. So,
Mhm.
okay, sorry, that was just a side point.
No problem. Good. It's all good information. So, next we have like, the type of pain, the severity of the pain. Stable chronic angina, the words stable and chronic are there, kind of let you know it's not going to be quite as severe as some of the unstable angina, the pre-infarction. It's more predictable, far more likely to improve with rest or medication, and it's going to improve over time because of the rest. This one's definitely far more associated with just like a stable atherosclerosis. Ba-ba. Next up, we have the unstable angina. So this is the type of anginal pain that can occur not just at activity, but also potentially at rest. It can be a bit more unpredictable. The word unstable kind of hints you at that. Not relieved by your rest, not relieved by your medication. The pain will be relatively the same, maybe, stronger, more strong compared to the chronic stable angina. Same type of idea. It's going to radiate to the same places, but this unstable angina, it's not going to be relieved with your less invasive medication, less invasive rest and medication. So this is where we start worrying about this more. We need to, what actions would you do after? Did I already ask that question? I might have. Oh, I said call 911. Okay, so what about when they get into the EMT? And like they come pick them up. What's like the next step? Follow your little like algorithm, the little acronym. Yeah. So how is this aspirin being given? Potentially O2. O2 can be given potentially. Yeah, so keep in mind chewable versus not, versus like, the enteric coated we give to some of the people that have like basically keep in mind that it's not the same as the EC because the EC you can't chew it. It's also going to be extended release. This one we want chewable that's going to act up faster compared to the EC. So that might be something that you need to look at. Maybe that could be like a way they try to trick you on the
Um,
test or on a Kaplan or whatever.
in terms of dosage for aspirin, chewing the aspirin in this kind of emergency, 81 milligrams times two, that's like the minimum. They usually give 162 or 325, so they could take up to four. But 162 is like your bare minimum. I just wanted to put that out into
Hmm.
the world. Okay.
All right. Yeah. Alrighty, alrighty, alrighty. So then here's some extra stuff, not quite as emphasized, I don't think. I don't recall. Kaylin, what do you think?
Nah.
With your pre-infarction angina and your
No.
Prince medal, not really as emphasized, right?
Mm, mm,
But again, you can kind of read and get the general idea. You don't have to have a PhD on angina or angina if you want to be careful with your pronunciation. Yeah, try not to tell the patient they have acute angina. They might hear something else.
mm.
All right. And kind of yeah, especially not after you just did a Foley on them.
That was such poor timing.
That was the worst timing ever.
It was genuine. He got screwed.
Oh man, it's okay. We love it. We love it here.
Good times.
So some general ideas here, chronic angina. Again, like I mentioned, like a fixed atherosclerosis. Um, I do have like a picture that might be helpful, but again, you don't have to be, again, this isn't a patho class. This is a interventions and management essentially when it comes to your priority. Kind of just from the book, kind of the idea behind the difference between the fixed atherosclerosis versus kind of like that unstable plaque. So just like extra information, but the general idea here would be you can have that plaque built up over time. The plaque might be above the vessel, it might be inside the vessel, kind of like this. It can pop, and that's where you have like an unstable clot, causes platelet aggregation to happen. Again, just extra info, but it's just like kind of get an idea of how the atherosclerosis causes the different types of anginas and stuff.
Anginas.
Angina, yeah, I should start saying. I think Salazar says angina. I'm like she's had her experience. I can tell.
Maybe.
Um, okay. So when it comes to general um acute coronary syndrome, we already talked about a lot of these accompanying symptoms. So we talked about indigestion, jaw pain, basically radiating pain, maybe like jaw, shoulder, back,
Or nor.
um, anything else that we talked about? Symptoms, indigestion, nausea, vomiting. That kind of goes with that, but I just want to emphasize the nausea, maybe like cold sweating and stuff like that. Um, then right here we have kind of the general idea between interpretation slash responding. So let's see how I can break this down. Ba-ba. Okay. I'm wondering what I was trying to get at here because I have it
I,
broken down in other places as well.
uh, girl, I don't know. I wasn't there when you made this outline. I can't tell you. I apologize. I genuinely don't know what I'm looking through because I was trying to figure out what you was doing too. You
I
brought
guess, yeah, I think I was trying to get at, we already talked about this, talk Mona slash Oanum.
that was gonna be my guess.
So, oxygen if they needed. We talked about the aspirin. It's going to be 162 to 325 milligrams.
Wait, I found it. I found what you were trying to do.
Hmm? Probably.
Okay, cool.
Let's see what else we talked about. The nitroglycerin and the morphine. The morphine typically, and being the last thing you do because the other options are going to be, better.
Does anyone know why we give morphine?
Does two things.
Increase pain and preload. Yeah, so it's
Yeah,
causing it allows so that the heart doesn't have as much oxygen demand. So it decreases myocardial demand by mainly dilating the veins very oddly. I don't want to say cardiac specific, but it works very well for your coronary artery vasodilation.
yeah.
Cool.
So essentially, it's a CNS depressant. So you're slowing everything down. If you're slowing everything down, that means your body needs less to function. Your body needs less to function, that means needs less O2. So if your perfusion's worse, then it's kind of like a little cheat code. It says, okay, I need less to function. Um, and it also helps with the vasodilation and all that stuff. So it has multiple uses in that sense. Something else that I think could be important is and I think something that I'm not sure who says it. I'm sure it's Salazar that said it, but your nitroglycerin is not really recommended for like a right-sided MI because of the effect of your preload. So when it's right-sided, you need that preload, and therefore it's not really recommended for that. So you kind of need to know. It helps to know what side of the heart is being affected.
It helps to know, but I think
It,
for this exam it was more generalized.
yeah, I believe so.
So don't let that trip you up, please. Oh, what happened to
Yeah.
me?
But what else do you guys think is important when it comes to this person that's coming in? All you know is that they have chest pain, they have they're like nausea, vomiting, chest pain that's not going away, shortness of breath.
We just have subjective data at this
Yeah,
point. I love
perfect.
that.
Yes,
Can't
awesome.
you
So
give me the time frame?
love that.
When will they be on a heparin IV? That's a good question. At what point can this person be on heparin IV? And STEMI. And STEMI, I believe STEMI can technically have it too. If you don't manage to get someone with a STEMI
Hmm.
to the cath lab in time. I've
Yeah.
seen I've seen people with STEMI with hepatitis
Yes.
as well.
Yeah.
Um, but yeah, that's definitely after you've done all of your evaluations and whatnot, and you've determined, oh yes, this person is having a heart attack. Oh no.
Yeah. Yeah. So essentially, yeah, NSTEMI or if they can't get them to the heart. It's a full moon. Everybody's getting a heart attack. The cath lab is full. I don't know. They're not able to get there in time. The heparin drip can work.
Yeah, because a lot of times your patients will come in and they'll be like, "Yeah, I have this chest pain. It started like, I don't know, like a couple hours ago." And at that point, it's like, well, we're way too late now. Like, there's not much we could do. The onset was so long ago. There are some patients that are like that, and at that point, it's like,
All
okay.
right. So if they are to be on a heparin drip, what do they need? How do we do that? How do we get what or what else? What other things do you want with the patient?
Please slap some
Yeah,
large bore IVs into
yeah.
them.
Get them some IV so that they can actually
Receive hep.
receive heparin and also actually draw the labs. So we're gonna large
Can
bore
I,
IV.
if I was to give that morphine, right? So the morphine is usually given IV push. Can I give it in the same line with the heparin?
Yep.
Please
So
don't.
keep that in mind. Heparin is its own,
She said negative.
should
I love
be
that.
in its own line
Yep.
for IVs.
Have I always seen it in its own line? A little bit debatable, but it should be. Should
Let me
be.
just double check the chat because glad you guys are doing a lot of good participation. Yes, I like that labs. So we have
Ooh,
cardiac markers. What's your most important one in
queen.
terms of looking for MI?
Trope.
Troponin, yeah, troponin one.
Props.
Troponin. Someone that comes in with shortness of breath, chest pain, they might also just kind of do a chest x-ray to rule out pulmonary issues, rule out um pulmonary edema, or like maybe also they would do like a BMP. If BMP is not MI specific, but if like the patient has a history of heart failure, that can exacerbate and cause the MI. And there are different cardiac markers too. The main one, though, realistically, is going to be your troponin.
It's more cardiac specific than the others because where did
Hmm.
I see? BNP is indicated for heart failure. So BNP is the what is it, enzyme or something released when you have stretch of the ventricle. So the more stretched out it is, the more it's released. So in our heart failure, a lot of times, we have that fluid overload or we have a lot of pressure backing up into the heart. Beach nature something peptide. I felt that on a personal level. Yeah,
Yeah,
I just know it as BNP. That's
yeah,
how.
yeah.
Um,
That's your di That's a diuretic.
Something like that. Yeah, you're the patho guy. What I know is that it's released when the heart's stretched and there's so much pressure in it. So that's why it's a really good indicator for heart failure because with heart failure we have that fluid backup. We have a lot of pressure that's being exerted in the heart just because we can't push it out. So that's why your BNP is a good indicator of treatment for heart failure as well. So what reasonably should be happening, your patient comes in BNP of 2000 in the sky should be monitored every day as you're giving diuretics and you're treating them to make sure that it is going back down. So just something to consider. Let's see. Is
Hmm.
there anything else I missed? Oh, oh, I already said that it was cardiac. The troponin was cardiac specific. Okay, cool. I think that's all I have to say.
Yeah. So you're,
For
if
now.
anyone remembers from 212, the ANP, that's the natriuretic hormone. That's your nat one of your natural diuretics, or diuretic hormones. Yeah. That's um that's a hormone. The BMP related, very related. The AMP comes in response to atrial stretch. BMP comes in response to ventricular stretch.
That's bougie.
But they have similar functions. They're diuretics, which is why your BMP goes up with heart failure because your body's like fluid buildup bad. Um, but we use BMP for the assessment because that one's ventricular and that's going to be more accurate for the heart failure than the atrial one. So that's just fun facts.
And the more you know.
Yeah. How often do they take troponin? Do you just go off the first one?
For
You
a second, I
expect,
thought you were asking me. It should be Q6.
yeah,
Some
usually
places do
Q6.
Q8. But Q6, PIH does Q6.
Yeah, Anaheim Global does Q6 as well.
If you're on a telemetry unit and you have someone that is there for NSTEMI or STEMI, um, make sure that if they did troponin, you could say like troponin was positive times 3, troponin was positive times 2, so that they know that, oh, it's a serial result. There's more results that are just like more nail in the coffin kind of thing.
Yeah. So you can have someone with their first one come back negative or like a small number, and then their second one is start to get elevated because an MI is not like a one, it's not like an immediate, yeah, there is. So I think here we learned just like anything above 0 is considered abnormal, but
Depends
the
on the and the unit of measurement.
yeah, that's also true. So depending on where you are, Anaheim Global, it was less than point 0.4. Yeah, anything less than point 0.4. Point 0.4 or less was normal.
Y'all at
But at
PIH
PIH, it's
is
probably a
different.
different number.
Yeah, so PIH, oh God, I got questioned on this in third semester, and I was like, ugh. Um, I think if I remember correctly, because it's divided into male and female there. So males is a higher number. It's like 54, I want to say, and females like 30 something. So just be aware of that if you do get asked that random question for whatever reason. But really pay attention to your unit of measurement, not just for your troponin, but for every single lab, right? Because like when we were taught white blood cell count, it was like 10,000. Oh, dang, like 5,000 to 10,000. And then you go to clinical and you see 5.2, and you're like, girl, what? So just be aware of the unit of measurement that you're dealing with as well.
Yeah, I think relatively speaking, you don't have to know. Like you don't have to. Don't worry about it. Like it's like the kind of questions will be more like, what are you worried about? Not like troponin, or they'll give you a troponin and then they'll give you a normal range to the side of it.
Okay.
Like when you guys get those iHumans where they give you the CBC or whatever and they give you their own like normal range and stuff. So for these kind of stuff, it's more about interpretation than like I memorized the troponin value. But just keep in mind it's a progression. Your MI is not just a one-time little insult.
Prolonged
It's a
insult.
prolonged, yeah, it's
Injury to
something that
insult to injury to insult.
continues, yeah, happening over hours, continues building over, all those hours and
Oh,
all that
Bella
time.
posted a YouTube video.
Huh?
Bella posted a YouTube video.
Did she?
Yeah.
All right, what did
Okay.
she post?
Oh, that's on 222.
Oh.
Okay. Sorry. Sorry.
Yeah, so we said O2 is applicable. So what would be some things that would be applicable? Maybe SAT02 under 90. I don't know why I put less than under 90. You're desatting, shortness of breath. If you look at this person and you think this guy could use some O2, just kind of use your best judgment.
I think on my notes for trope, I have 12 to 24, but I think on our notes it was also from like first semester that we copied and pasted it. So,
I think this is actually from Salazar. This
oh,
came from her.
ow. Okay. Yeah, peak we have 12 to 24
Yeah,
here. If patient needs rescuing.
yeah.
I love that. Yes. That'd be my kind of like they start going down.
Oh, cool. Ashley says she asked Salazar about the O2,
Good.
and for
Good.
test purchases always give O2.
I'm so glad you asked that because that's what I got screwed over in. That's what I got screwed on. I'm still very upset about it.
That's nice.
You're a real one for that. We have closure. So I know that I got those wrong. My bad.
Other than that, I think that's pretty much it on everything. I think we got everything. Here again, they exist, but focus more on this troponin. So troponin, what's going to tell you if someone has an N-STEMI? How do you tell if someone has uh, it's going to be your troponin, your EKG. A lot of that can tell you a lot. Let's see what else here.
Is
Here
that
I have ACS for general unstable angina,
angina?
angina. Sorry, I should start saying angina. Troponin elevated in MI in general, not in STEMI versus. Troponin's going to be elevated in MI in general. So NSTEMI versus STEMI. STEMI stands for ST elevated, MI. NSTEMI stands for non-ST elevated MI. General idea is MI has some sort of heart damage.
Which one is where the troponin isn't going to be elevated right away?
Definitely more like I would imagine more likely the NSTEMI. It's not going to be a series of an insult.
Sure. I mean, it still takes
Yeah,
it takes a good amount of time for the onset, but I believe the initial number that you'll see will be higher with STEMI. If
yeah,
I'm gonna take a wild guess out there into the world.
yeah. And also keep in mind that um, even with an ST elevation, you still need the cardiac markers. Someone with a history of an MI or a history of heart stuff can have like a chronically high ST. like chronic ST elevation from permanent heart damage.
Yep.
Um, and you can actually have, believe this is something that she mentioned to us. Just again, fun fact, you can have ST changes on an EKG without the cardiac markers. Um, so
Depending on what's going on.
unstable angina could cause ST elevation.
I
All
believe
right.
I also saw, like, as of more recently, I saw someone who had sepsis, I believe, that had ST elevation, but no elevated troponin, something like that. I remember being like, oh, that's crazy. And they were like, oh, yeah, we attribute this to
Oh, okay. Maybe the catecholamine.
something. Girl, I don't know. That's too bougie for me.
Yeah, but let me see what else I got on here. So general unstable angina. God, I don't know why I put all these things here. It's like I don't remember what I want here.
Have
Let me
fun, girl.
You're supposed to support.
What do you mean? I'm saying have fun. This is supportive. You're welcome.
Yeah. I
I,
mean,
I
in general, I think this is like you're pretty good. This is pretty good. Unstable in general. Yeah, this is the same. I don't know why I did that. Kind of just treat this as that. And then here it's just more specific breakdown of NSTEMI versus STEMI. So we talked about your ST elevation. So NSTEMI is non-ST elevated MI, and STEMI is a ST elevated MI, and that's related to your EKG. I don't think you really need to go too hard on that for now in terms of you're not going to have to read an EKG right now.
no.
Yeah.
Ow. She said T
So I'm
version
just
with the
reading what
ST.
Michelle says. Last may not, yeah, it may not change, but it can change in terms of I was saying labs, I guess. I was talking about the EKG in that sense. But yeah, your unstable angina might not cause any labs to change, but it could still cause like ST elevation. Okay, okay. Oh yeah, yeah. T-wave inversion with ST depression for NSTEMI. Yes. So
Bougie.
that is bougie. Typically, this NSTEMI represents myocardial ischemia and like, but not necessarily like a full obstruction. But because it's still an MI, it's still associated with some heart, a little bit of heart death. No, don't worry about that. Like,
I thought that. I was freaking out.
there's a 100% occlusion on the Widowmaker. What do you do? No, don't worry.
You pray.
Yeah, you get the chaplain. Yeah.
Jessica did the same thing.
Holy water IV stat. Like, I don't know.
Yeah, the Widowmaker's that lady.
Yeah, 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 yeah. Yes, it does.
Oh god. I'm losing it. That's why it's called the Widowmaker. Because it'd be making the other one a widow. Call an ambulance, but not for me.
Oh my God.
Okay, I'm done. I promise.
Yeah. She does mention, type 1 versus type 2 MI, and that's referring to the end STEMIs, but don't worry too hard about it. It's a little extra. She was nerding out. I have,
Let her
that's,
nerd out. She's having fun.
but the general idea is that your type 1 MI is your typical end STEMI related to, the platelet aggregation thrombus leading to occlusion versus yeah, yeah.
That do give me
And type 2 related to, uh, just like really bad hypoperfusion and other causes like sepsis is actually one of the causes that might lead to that. So sepsis can be one of your causes for MI as well, or it can even be vice versa. Well, not what the hell did I just say? Yeah, the
fun.
sepsis can cause
Am
the
I? I
potential MI.
was like, I don't think an MI will cause sepsis.
No, no, I
Live
just
your
like
best
what did
life.
I just say? I was like, whoops,
Live your best life, man.
I caught it. Sheesh. I was like,
Ow.
wait a minute. Let me take another energy drink swig real quick.
Schwig. Oh no, I didn't finish my smoothie. I put a lot of cinnamon in it. Cinnamon.
Very cinnamony.
Yeah, maybe a bit too much.
But yeah, so ST elevation MI. I don't think you need to particularly know this, but ST elevation on 2 leads on a 12 lead EKG to officially diagnosis associated with uh full what's the word? Obstruction. Oh, occlusion, that's the better word. Necrosis of cells, right? And then additionally, afterwards, that person may have chronically elevated ST. Yeah, I guess we'll go with that. Like boop, 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 boom. And we talked about, in general, this is going to be your cath lab within 90 minutes, and that's a key thing. So just don't, remember that. So cath lab within 90 minutes. Remember your Oanum. Oopsies. Did I spell minutes wrong? I spelled minutes wrong. Oh my God.
The
It's
moonits.
minutes. Yeah. So this is the key thing. They probably said it a billion times, but we're saying it a billion times again. And there's a whole bunch of extra information like LAD versus circumflex, but don't worry, it's okay. It'll be okay, guys. It's okay.
When does it happen?
But management, so we talked about that. When it comes to the your chest pain, that's the PQRST. Get some of those other atypical presentations, the jaw pain, shoulders, SOB. Get your vital signs. Um, I'll do that.
Strawberry.
Okay, okay, okay. Other things that you might want to do. I guess we can add that on to here instead. We've been talking about your cardiac markers, troponin,
Trope-a-dope.
Q 6 to 8 hour times 3. Your peak is 12 to 24 hours. There is a troponin T, which would be MI that occurred previously. I think it has like a 2 week, I think up to 2 weeks that it stays
Yep.
in the body.
T for two.
True.
Two for T. Toopity-bee. Happa-pa-ta-pa-pa-ta. Happa-pa.
So that's for if happened like 2 weeks before. Yeah, essentially, yeah. So it's like, did you have one? Remember that? Remember that chest pain that didn't go away and the shortness of breath you had and you didn't
That
go to the
sounds
hospital?
crazy.
And you told your wife you'd be fine?
Mm. Oh, that. You know, I do have a story about that, as unfortunate as this is about to sound. That is actually the last day of my 240 clinical. I was helping one of my friends, like I forgot if like he was helping intake a new patient, something like that. But so he was in the room with the patient. I was like, oh, okay, like let me go be a chismosa. And like so I went in there too, and I'm talking to the patient and the patient's spouse, and I'm talking to them, and they're describing to me like how he ended up in this position. And it was basically that the patient had like infection. He had an infection somewhere. I don't remember where, told the wife, "Oh, it's okay. I'm fine. I'm not in pain. I'm not in anything." And then it like just progressively got worse. Um, got really, really pale over the course of like 2 weeks, really sweaty, diaphoretic. And then he got chest pain in the morning and just looked over at the wife and said, "You got to take me to the hospital." And that patient ended up having an MI and sepsis, went
Yummy.
into septic shock, and I saw him get intubated. Uh, so anyone out there that's like, "Oh, I'll be fine." No. No. Let's not do that. That was something that stuck out in my head. But you'll have a lot of patients that are like that too.
But did he die though?
I don't know. He was
But
intubated and wheeled
if
off
he
to the
if he
ICU.
lived, he proved his point. He was fine.
Oh. My God. I don't want to talk to you right now. It is always the stubborn old man. That's my dad too. Ugh, men. Grandpa gonna be he's good. He's still kicking.
You don't get it. That's his pride.
Wait. Oh, I love that.
If he goes to the hospital, it's admitting he's wrong. He'd rather be right than be alive. So.
Kevin, don't agree with him. Kevin, don't agree with him. No, it's
He's
not the
giving you
time.
he's giving you a job, Kevin. Agree with him.
Or wait, actually, maybe. That's a good point. Okay. Sorry.
Yeah, sorry. So other things that make sense. We talked about the EKG. We talked about the PCI. Got into the cath lab. Another thing that we can do. We talked about how you might still want to check the BMP, just potential like heart failure that led to exacerbation of heart failure that led to a an MI. So you have like some people that like I'm sure you've had patients where like they clearly look like they're sick and they have a lot like they would look like they had a extensive medical history, but their medical history is pretty bare because that's like the first time they actually went to the hospital. So
That's my dad.
maybe they've been having heart failure this whole time. So but it was just never diagnosed because they just never went to the hospital until it's like, I feel like there's two elephants on top of my chest today.
Or no.
So you can still do like an echocardiogram, see what's going on, see how good that heart's functioning. And that might also go with some of your assessment findings. So we talked about the PQRST for pain, the EKG is still like an assessment, vital signs, see how that SATO2 is doing, see how their blood pressure is doing as well. What else would you want to assess? Should we know the older considerations for CAD? In what sense?
Oh, forgive me. Oh.
Oh yeah, that kind of goes here. We mentioned the chest X-ray, stress test. That could be something that's done. Yeah, stress test. So it's like a stress test plus
Plus
echo.
echo.
Um, sure, why not?
You
Like I
could do
said, go into
angiogram
that.
as well. Yeah, most definitely. You want to be able to see, well, that kind of goes along with PCI, but that's
Yeah,
intervention. But angiogram to see how occluded any of the vessels are up there, right?
yeah. And I guess yeah. What would you call these labs? The fat labs. What do they call
Lipid
them?
panel,
Lipid panel. True.
the fat lab. Don't talk about my dog like that. My fat golden lab and fat labs.
I like fat labs.
Yes, it does detect coronary stenosis. So you're able to see the degree of occlusion when you do the angiogram because your angiogram is just pushing a whole bunch of contrast dye through it and you're able to visualize it. So if you see and it's like, oh, it's going good. Oh, it's getting really, really skinny up there. And then it opens up again. It's like, oh, there's the area of occlusion. Or, God forbid, you have a complete occlusion and it's like, oh, it ain't going through anymore. It stopped. Definitely an angiogram's a really great thing. Um, is it CT or MRI? She said Roblox. No, so your angiogram is done with what is it? Under X-ray or something? But not CT, no MRI, I don't think. Correct me if I'm wrong, Diego. It's been a while since
For
I've
what, the angiogram?
Yeah, like what is the how do they put the imaging up onto the board? Is it
Uh,
X-ray or is it
it's
something?
definitely with a contrast.
Oh wait, is it CT? Am I tripping out?
I think it probably is. Well, let me see how they. I'm gonna look this up. X-ray or CT? CT is basically a fancy X-ray. Yeah.
Well, I found out something new today. Cool. I never really questioned it. I was just like, yeah, you put it up on the screen. Sorry.
Where were we? Other thing I wanted to talk about is for in terms of your assessment. She goes over this. Just something to keep in mind is the cardio assess for like cardiogenic shock.
Wait, they talked about cardiogenic shock in
Yeah,
there?
very lightly.
Oh, okay.
It's like a potential complication. Yeah, just the symptoms. Just gotta be able to recognize symptoms. Perfect. So you guys already got that down. It's a type of shock, so expect hypotension as PCI is done for both NSTEMI and STEMI. Galen, I think
Huh?
s- PCI is done for both NSTEMI and STEMI. I
Mainly
think
done for
more mainly done
STEMI.
for STEMI, right? Yeah.
So, for NSTEMI, you could go in with PCI and do balloon angioplasty. So you basically shove a balloon up into the vessel and inflate it so it pushes all the gunk, all that fried chicken you ate last week. It pushes that up against the vessel. And then you could place stent. You could do it for both, technically. It just depends on the percentage of occlusion. Bro, the wire for PCI, it is very long because they go in through a lot of times they go in through the femoral artery. So they go in
Hmm.
right right where the sun don't shine. Um all the way up there. So it does have to be very yeah, it's got a long way to go. Yes, it could also be clot retrieval, balloon and stent. Um let's see. If NSTEMI does not require PCI, would it just be treated with thrombolytic or hep drip? Um Thinking on that one. It's not always hep drip. Yeah, I was like, I don't think I've seen very many N STEMIs that have had heparin drips, but I'm trying to remember. I just realized, you know what, Diego? It's been such a long time since I've had a heart patient.
Really? Oh, I guess so. You've been at the
Yeah.
ICU this time.
Yeah. I'm like, I was sitting here and I was like, I used to know this like the back of my hand, but I haven't had a heart patient in so long. I'm starting to trip out. Oh my gosh. Give me a second. Sorry. 4 to 6 hours would be way too late for STEMI. Wait, where are we? Where's the question? I know I saw it.
He's asking about NSTEMI.
Wait, where'd it go? The wire got a long way to go. Unclogged the clogged artery. Then STEMI. Oh, does not require there it is. That's the question. And STEMI does not require PCI. Oh, it's the stents. Oh wait, that you're asking if it doesn't require the stents in the balloon. Yeah, you definitely have a bigger window to intervene because the percentage of occlusion is definitely not that bad. Where is it? Where is it? Positioning med, sure. It does seem to be thrombolytic, so you have, what is it? Where is it? Well, antiplatelets, that PCI, hep infusion, mainly for STEMI, but I've seen it for NSTEMI as well. Yeah,
Maybe
kind of.
one of those not endar what's it called? Not atherectomy maybe?
I don't really see that.
Uh, the little
But yeah,
spinny thing. Be like, brrr.
yeah, I don't see that as much. I just want to differentiate between these treatments and NSTEMI and STEMI. That's for NSTEMI if cardiologist deems them not immediately in need for cath lab. It's more narrowing, yeah, narrowing an NSTEMI, so it's not a full occlusion for NSTEMIs. I'm tripping it, but that you're talking about STEMI. I'm getting, girl, I was sitting the same thing. I'm like, I'm getting confused. Forgive me. Thrombolytic something or other. That's what I was thinking. Okay, cool. Yeah. But yeah, for your STEMI, there's not much else you can do. You have to get in there and you have to dissolve the clot or if they don't make it in time for your PCI, then you start them on heparin drip. There's not too much else you could do for that. Your NSTEMI has a bit more like or a bit less invasive. You could still go in with a PCI, you could go in with balloon angioplasty, place a stent, but you can do medications as well. So you could do maybe subcutaneous heparin along with antiplatelets as well, and medications to manage the other coexisting comorbidities like your hyperlip, hypertension, diabetes. It's kind of, how do I say? I don't want to say multimodal per se, but it's definitely not as invasive as your STEMI. So your management for NSTEMI is a lot less critical than your STEMI. They're
Mhm.
going to be more stable patients. I would say it's a bit more conservative. STEMI is definitely they're both emergencies, technically. STEMI is definitely like, "Oh, Jesus, you need to clear out the cath lab, and we're running down there." Because STEMI is the one with the higher percentage of occlusion, so time is tissue, and as as a person with a ST elevated MI, as time goes on, more and more cardiac tissue's dying because let's say 90%, 95% of that coronary artery is occluded. So that's why you really need cath lab for that, or if you don't get to the cath lab, Necrosis City. Welcome to Shell City. Um,
Chelsea.
Shell City. So if you don't get to the cath lab, you're doing a heparin drip for that one. Your NSTEMI, it's I don't wanna say that it's inherently, like, because you could still do hep drip for it, you could still go in with your PCI, but your time frame's not as bad because there's a lower percentage of occlusion, so more blood is still getting into the area. It's still gonna cause damage, um, but it's not as critical. Cardiac cells do not oh god, what is this? Oh, Lord. STEMI requires immediate reperfusion therapy like PCI do. That is Yeah, that is basically the summary of what I've been trying to say for the past 5 minutes. Oh my god, yes. Thank you. Lord help me. Yes, that. Just look at that. She put it in quotes and everything.
Where's the citation though? Ooh,
She
just
said,
kidding.
"Google ah, whoop." I'm scared.
Just kidding. But yeah, when it comes to cardiogenic shock, you'll notice this looks a lot like your hypovolemic shock. Some of the main differences you don't need to know. Like the main difference would be something that you don't need to know yet. In fourth semester, you'll go over more of the specific types of shock. Um, there's a measure, there's some sort of assessment or like a lab value that goes with this. I guess it's not really a lab value. It's related to not an arterial line. They have like a something called a Swan-Ganz catheter. You can get more accurate measurements of central venous pressure and stuff like that. But for now, just you can see here, it's pretty much all your hypovolemic shock symptoms. Your hypotension, you compensate with tachycardia, tachypnea. Over time, you end up shunting, so you have cold and clammy skin. Your pulses are weaker. Your body's not as focused on urine production. Your urine production decreases. Could also be a sign of um, your kidneys starting to complain about their lack of perfusion, get into like more of that compensatory stage. That's pretty much it. So here we're going to talk about the PCI. So minimally invasive procedure to open up a blocked coronary artery, restore blood flow. A lot of the time, that catheter will have a balloon, inflate to widen it up. What a Chris post am I? Oh, the cardiogenic shock. Cardiogenic
It
shock
could.
might be caused because like because of the MI. Um yeah, so cardiogenic shock is essentially like a pump failure, your inability to pump. So because you're unable to pump, you have fluid buildup, and that fluid buildup makes it even harder to pump and get blood flow going. So in that scenario, you're going to be hypotensive because your heart's not able to pump the blood out. So you're not getting any real movement, but you can have that happen due to your heart damage. So if it has significant heart damage, it's not able to pump appropriately. And there's other things that might cause it, but in terms of this, we're referring to significant heart damage. It'd be the other way around. It'd be more like your MI causes your cardiogenic shock because the MI is leading to heart damage. Heart damage, then your heart doesn't pump good. Heart don't pump good. Go into shock because you're not getting perfusion. Does that make more sense? Yeah. So I'll kind of write that down. MI heart damage. if significant, can lead to pump failure, and that can lead to cardiogenic shock once it gets really severe. But yes, you can have the heart failure also, do just like the congestive heart failure. But this would be like a more serious thing, in
Ow.
which case the patient probably needs those like positive inotropes, like your um
Dobutamine,
yeah,
dobutamine, digoxin,
digoxin, yeah.
any of your things that help pump it forward. But I think, yeah, I don't think that's as of much importance as of now.
Yeah, don't worry about that. Just know how to recognize it for now. But yes, the PCI is your gold standard. We've mentioned this. We're beating this to death within 90 minutes.
For your STEMI.
Yeah, for your STEMI. I guess I'll specify. Because you
Definitely
can,
specify
yeah,
that.
because your N STEMI can wait considerably longer.
You can wait. So it's safe to say cardiogenic shock is the acute complication in heart failures long term. Essentially,
Essentially, but
I'll
you
believe
can
that.
have heart failure on its own.
Oh, I think I misunderstood that a little bit. I was thinking like if you were to get an acute complication, it would likely be cardiogenic shock, and if you were to get a chronic one, it would be heart failure.
Oh, yeah, that's also true.
You could also very technically have an acute heart failure, but that's another story in and of itself.
Yeah.
Ouch.
All right. So another thing they mention is your PCI can also be a bridge down the line for a cabbage. You're already kind of in that area. Um, you can open things up and then be like, okay, we need more roads in this freeway. And yeah, placing stents and stuff as well. So what I think is important to keep in mind would be what is going to happen before the procedure and after the procedure. So what are the important things before the procedure? And just keep it keep it basic. Yep. Vital signs, informed consent. Cool. Hydration, he said. You're gonna lose a contrast. So contrast is used, therefore you need to be check allergies. Maybe you need to give Benadryl before if they're allergic to shellfish or stuff.
Crystal pulses and stem temp.
Yes.
Yes.
Why'd you say it like that?
I don't know. I think I've been stuck on like I keep seeing this meme from like the new Wicked movie where like there's a part in there where she's just like because they were and then the other person says like popular and Ariana Grande's like yes. Sorry.
PCI.
Yeah, so your PCI, it's important to basically do CMS on both lower extremities, but you're really paying attention to the one
Also,
that it was inserted into. Because your risk associated with your PCI is hemorrhage or the complete opposite of that, where the artery just kind of squeezes in on itself. So you're either bleeding out of that insertion site or there's no blood going down because it's basically spazzed up. Where am I at? Assess renal studies because contrast is nephrotoxin, and you could totally end up with an intrarenal AKI. Aha. Let's see. Lung and heart sounds. Where are we at? What are we at for HHB on? Wait, what labs were you asking for, Diego? Sorry.
huh?
What labs were you asking for? What was the initial question?
Well, what question? Did I ask a question?
I don't know. I thought you did. Now I'm starting to trip out. Oh my gosh. What what we doing right now?
Oh, okay, sorry. I was just looking something up.
Oh, okay, cool.
So I think like optimally you want to be MPO, but if the patient like has a heart attack and has a STEMI like an hour after they ate, um, depending on the situation, they might be like, okay, well, whatever, we'll do it anyway. Or if maybe it's a STEM, like they might just be like, okay, maybe the occlusion's not as bad. They do like a heparin drip. How long are you gonna get from consent for PCI? The
You know
patient
what,
springs in mind
Michelle?
that
I
moment.
actually asked that question and I'm trying to remember the answer because I thought the same thing. If I remember correctly, like especially if your patient is like not there, like
Hmm.
not really there mentally. It's kind of like risk versus benefit. Like
I
if
like
we,
that.
yeah, it's like do now, ask later kind of. You basically get like kind of like a verbal one, like, hey, like we need to do this. If you don't do this, like you're kind of not going to end up too good. And they're going to be like, okay. And you rush them over there. But yeah, you kind of you're right that it's like a very big time constraint there. So you kind of just do it and then ask questions later for lack of a better terminology. I can't get this to work. Cursed. Na, 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 na.
Mm. Okay, let me see what else. Oh, IV access. Yeah, that's good. Let's see what else. The renal labs. Yeah, sure, for like the contrast and stuff. Sure. Although I think it's like, you know, if it comes down to it, you would be like, we can kill your, we can mess your kidneys or you can die. Kind of, it's like
Pick your
whatever.
fighter.
Yeah, it's like you'd rather be alive, probably, or maybe not. Honestly, who knows? Honestly, with that renal diet, maybe I'd rather be dead. I don't know.
Shut up.
Running routes for renal protection. Interesting.
Wait, where are we at?
So like one of the things that because like what Ryan's talking about is, and I think I have it too, is like IB fluids for rehydration. I mean, I guess IB fluids is different from being MPO. That's fair.
That is, yeah, those are
Yeah.
two different stories. Oh, in
Uh,
terms of percutaneous intervention.
yeah.
That makes sense. Yeah, that do be making sense. Hold like six per clinical judgment.
Hmm. But yeah, what about, let's see. Is there a reason I separated them instead of just
Don't know.
me? Just kind of think about. Oh, I put during procedure. Okay. And why did I do that?
I think you were trying to maybe you're trying to differentiate like for NSTEMI, like this is what they're doing with PCI, and then for STEMI, this is what
Hmm.
they're doing with PCI.
Sure. I guess
If
we'll
I had
just
to take guess.
maybe. I guess we'll just talk about it. Kind of like, okay, you see a clot, remove clot. Wow. With an N STEMI.
They can definitely bleed a lot. But it's such a small initial incision that it's very unlikely that they're gonna bleed out.
So with NSTEMI, you might have more of that balloon angioplasty, widen up the area because NSTEMI more likely to be caused by fixed atherosclerotic plaque. So the plaque blocking the way. So let's kind of take a look at that atherosclerotic plaque, atherosclerotic, maybe something like
Oh, you
that.
got to
Or
see one?
ooh,
That is a bit strange just because the incision site itself is so minimal. It is going in through an artery though, so if like that pressure gauze and your pressure is not applied immediately after, that's gonna cause a lot of blood. But I think like I think I was misunderstanding and thinking like during, like completely during, but I don't know. Why are we holding Lisa? No, she said that achy, but then she said use clinical gen. What the heck? She said hold Lasix, but didn't give an inherent reason. Okay. Do you remember if we were told anything like that, Diego?
no, but it makes sense that it'd be more like related. If you're worried about the kidneys a lot, then Lasix is stressing the kidneys out, and you probably don't want to stress the kidneys out when their perfusion's poo-poo.
Yeah.
Ba-ba-ba-ba. Okay, so basically, but we talk about, we said this is important. Know what to do before, and then definitely know what to do after. Know your complications. Here is just kind of the general idea. Clot seen, remove clot, you can place a stent. Widen the vessel because it's more likely to be caused by this fixed plaque. Ba, 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 ba. There we go. So you can see here how there'd be a narrowing being caused by this little fat that's making this more and more narrow. Eventually, it's starting to occlude the blood flow. But this would be different compared to like a little blood clot or even like the atherosclerosis when it's underneath instead of it being kind of like on top of the vessel, it's kind of in that little in this like small little layer where it might grow, burst, kind of like in this first picture we had somewhere over here. Because the big issue here is that because this is kind of in like a little cap, you can see kind of here how it's like underneath this little layer. This starts building up over. So this person in this one has kind of like that plaque on top of the vessel and a little bit of a lipid pool inside of this layer. If that thing bursts, causes a bunch of platelet aggregation, and you can have blood clot on top of that. So that's where you get more of a more of the STEMI, where you have this clot alongside maybe some fixed atherosclerosis as a due to like unstable plaque, which would be this type of plaque, because this type of plaque could burst and then cause platelet aggregation. Yeah, let me see. So Michelle says for post-op, we're monitoring for bleeding, check peripheral perfusion. Complications include early dissection of thrombosis or reocclusion of the vessel. Yeah, seems pretty good. We can write this stuff down. Boo, boo, boo. How did I get all the way up here? Oh wait, oh, you can see that now. No. Okay, where are we? Post-op. So some of the things that I expect you guys to like immediately, like if you see this on a test question, like you'd be like, yeah, do I check their vital signs? Yeah. Yeah. Just in case you didn't know what a cabbage was. So like every 15 minutes, we're gonna assess the patient maybe for like an hour, and then we're gonna switch up to Q30 for the next hour, et cetera, et cetera. Maybe then 1 hour, and then kind of keep going. Yeah, essentially reassess everything. So you did an intervention, you assessed before, you did an intervention, you're assessing after. You're checking the incision site. Is there making sure there's enough pressure? Enough pressure is needed on the site to prevent bleeding. Yes, so that especially because it's a lot of times it's done femoral, so you're gonna want to make sure that that person is not bending their leg. So make sure patient is flat and not bending their leg, the femoral route. So you want to prevent bleeding or hematoma. Let me see, monitor skin temp. So we're worried again about any type of um, infection or maybe even like shock, like clammy skin. Other things that you might want to worry about after like urine output. Yeah, EKG, all their basic stuff. So we're gonna do like assessment of heart and lungs. What else could be good? Heart, lungs, peripheral pulses again. Um, patient's skin color, temp. Are they warm and dry? Are they cool and clammy? Are their pulses okay? Resume any medications. Check the EKG. So a lot of the stuff that we were worried about in before, and we probably did here, we're gonna kind of get a relook at again. And we talked about urine output. Uh, we were worried about the kidney lab, so we're just gonna do urine output to check how much urine we're making, how good the kidneys are working still. Um, all of that good stuff. So we want to drink plenty of fluids to flush the contrast as well. Yeah, so like some of your labs. So like maybe your renal labs, because the patient had the contrast, they likely had issues with their perfusion, so you're worried about the kidney stuff. Yeah. Basically, a lot of this stuff that um, if you were to see it on a test, you'd be like, yep, I can click this. This makes sense. I think this one's pretty good to keep in mind for sure, just because that might be. I think if you had a question, they'd probably specify this was done through the femoral route. But if for some reason they don't, I mean, they probably would, but it's just something to keep in mind. In general, with anything that's done through the femoral route, make sure that they don't bend their leg because they don't want to be they don't want to have any bleeding and stuff like that. No hematoma. Is enough pressure that I forget infection. So just as always, you have a site. So assess for an infection. Oh, nice, like a little splinty thing.
I don't think I've seen one for a leg personally, but I have seen one.
For like an
Um,
arm.
yeah, I saw one on arm. Like they
Nice.
went in, I think, what is it, radial? So they had
Hmm.
an arm board on them to keep it straight. But it wouldn't surprise me if you have, especially if you have a patient that's, uncooperative or unable to understand the instruction, that they would have some kind of board or something. Yeah, I was like, probably kept bending it. Or he had
Huh.
a risk of bending it, like maybe he was already altered before he went in. But she said he had the fem stop.
Oop.
Interesting. I learned something new every day.
Let's see what that looks like. Femo stop? No. Is that it? What the?
Uh, Miss Girl, what are you up to?
Well, I'm looking at what he said. Is it called a femoral stop?
Yeah, those X's on the feet definitely make your job a lot easier. So whoever marks them, like God bless their soul.
That's funny.
Seriously.
Well, I didn't really get the picture I wanted for that. But complications, reactions to the contrast, stuff happening related to the PCI, reocclusion of the artery. So essentially, they get another MI.
Yay.
Yay! But that's kind of the gist of most of that. The rest is just kind of review on stress tests. So stress test would be a way to see how the patient is affected by stress as implied by the name. So they would kind of check their EKG, either make them walk on a treadmill or they could go through medicinal. So like the Lex scan, they give them IV um, medication and see how the heart reacts to stress essentially, and see what goes down. So what are you assessing with the person? So let's see, assessing how the heart, so assessing for EKG changes. What else? Symptomatic, yeah, if they're symptomatic. Symptoms such as chest pain, shortness of breath. Yep, yeah, I like that. You can also do an echo, yeah. So you can do an echocardiogram as well, like before and after, like during the stress test actually. Um, Yeah, that's kind of it really for this. It's just kind of what's the purpose of the stress test? What are you looking out for? You're looking out for how their heart is able to handle it. You can do this by assessing EKG, assessing the echocardiogram. how is their heart functioning before and after. So then we're going to talk about really quick just over cabbage. You don't really need to know too much about cabbage. Um, when it comes to is the echo the same thing as a 2D echo? I know they have like a 2D, they have a 3D, they have a transesophageal. What do you know about it, Caitlin?
Well, they're not likely to do a TEE or TTE.
Uh-huh.
The cabbages. It wouldn't surprise me if it was a 2 or 3D echo. I assume echo is echocardiogram. Yeah, 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 yeah.
Yeah.
But for this, no. Your TEE is going to be mainly looking if they think that there's something maybe like posteriorly, like if they want a different angle from the echo, they'll go that because that's pretty invasive. It's a big old thing going down someone's throat. Um, yeah, you could do it's basically a heart ultrasound, Lord help me. But yeah, they'll do TEE for that, or if they have like let's say infective endocarditis to look for any kind of vegetation on the heart valves. But for stress test, no.
There you go, Google.
Just confused myself. Yeah, so 3D you get more data essentially vegetation. I'm sorry. I made an accidental joke.
Well, actually, I mean, you can have like that's what they call it when it's like a endocarditis. The little bacterial growth is called the
Else.
vegetation. Isn't that great? That's crazy, huh?
Eat your cabbages or else you get a cabbage. Unfortunately, that do be kind of correct.
No, honestly, I didn't know the difference between a cabbage and lettuce until like a few months ago, honestly.
I think I was the one that had to tell you the difference.
They're both green.
Oh my God. I'm never sending them to the store. It's over, guys.
Well, I'm also Hispanic, so you can't tell me to buy lemons because I'm not gonna know if you want the yellow lemon or the green lemon.
Not the lemons. The scientist was hungry when he came up with these. I think so too. I always thought that was such a funny acronym for it.
Well, I'm not Mexican. I don't think
I was just about to say, I was like,
we don't
mm.
use cabbages. Oh, Mexicans use cabbage a lot, I think, but I don't. Peruvians don't really use cabbage. Not really anywhere near as much.
I don't know, bro.
Yeah. But let's see what else do we know.
Peruvian use potatoes.
My dad eats rice and potatoes with everything. That's true.
Oh
My
my
dad
God,
will
he's at
eat a
risk.
plate of spaghetti and then ask for potatoes or rice.
Wait, oh my God, he's at risk. He's at risk for CAD.
Yeah, he is.
Oh my gosh.
But here's just kind of an idea of the bypass. So, they take I think they take an artery, right? They take an artery from a different place
Mhm.
and they essentially create a new road. And you can have a single, a double, a triple, a quadruple little bypass, creating new roads for the blood flow to go.
Yep, saphenous
You,
artery is one of
yeah,
them.
you don't need to know the specifics of it though.
So
Don't worry
saphenous
about
from
it.
the leg or the internal mammary because of its location and it being like very oddly convenient to do. But yeah, they could take artery from different places and you basically just build a new road. You pass
Hmm.
around the area of occlusion and create a new pathway for blood flow. That's the basis of what a cabbage is.
Yeah,
At this point, I think that's really all you need to know for it. I
yeah,
don't think there's too much else you would inherently have to know.
yeah, not much. And just for clarity's sake, when someone has a history of cabbage times three, does that mean they got a cabbage? Uh, they got a cabbage, then they got another, then they went back to the hospital, got a cabbage again, and then went back to the
Cabbage sick.
hospital, got another cabbage, or is it just all three at once?
I've had people that were the quadruple before.
I think I've had up to three or four. Yeah, it's all of it at once. Just remember Miss Fletcher asked me that. I'm like, I think it's all at once. And she's like, yeah. I'm like, all right, cool. And then she asked me what the name of the incision used to open the uh just to like open the what's it called? To get in there. I'm like, what?
I can't answer that.
Sternotomy.
I don't know.
It's close. I think yeah, sternotomy.
Um,
Oh,
she
did she?
asked me the
Haha.
same. Oh God. Well, ectomy makes sense. Otomy is a hole. Ectomy is just a cut.
Well, ectomy would be removal of.
Oh,
Otomy
girl, I don't know.
would be an entry point. So let's take a look at that just for
Oh,
fun.
girl, I don't know my medical terms apparently.
Sternotomy is just a cut. Sternectomy would mean that they literally took out the sternum.
Oh, my bad, chief. Post-CABG, the patient
See?
is definitely at a high risk of dysrhythmias. No, you don't need to know much else. You will
Oh,
go over.
technically too, mine too.
Okay. In fourth semester, you will have to know that like your post-cabbage is at risk for one specific type of dysrhythmia, but at this point you don't need to know it. English is my second language, my bad, G.
Yeah, so post cabbage, the person might have AFib after. I believe that's the most common
Yep,
one that
it's
people
very,
get.
very common.
hmm So here I pretty much just wrote all the stuff for you just so that you can have it because again, I don't think it's as highly emphasized. You don't have to be a cabbage god. Um,
Cabbage.
yeah, so here, return that blood flow, get that extra lane on the freeway. Here, extra info. And the entire purpose of this is to improve oxygen delivery to the heart, trying to relieve those symptoms because more O2, more better.
Is the blocked artery removed or cauterized? If I'm gonna take a guess, cauterized, but I don't know the exact answer to that one. If you have Pathoriz, God, Diego.
Hmm. Is the blocked artery removed or cauterized? I don't know. Wouldn't,
That's something that we've actually never gone over, and that's again something I've never questioned. I'm just like, yeah, it exists there.
I mean, if you're already in there, you might as well just like unclog it, no?
Well, they got to the point that they needed a cabbage because they
Hmm.
couldn't physically unclog
That's
it.
true.
That's why
Um,
cabbages happen.
I feel like you would just kind of
But
just
in
like
terms of removal versus cauterized, I would assume cauterized, um, just because it would be
more,
least
yeah, it's less
invasive.
invasive, right? Instead of like going out of your way to remove it, just like be like, okay, you
But this
can
is purely a guess.
conjecture.
Whatever that word meant. It's something that we haven't gone over, and that's something that you don't inherently have to know either.
Yeah.
Blood pressure cause hypertension can cause bleeding from the graft, but hypo can cause the
Yes.
graft to collapse, and that is exactly correct. So they
Yep.
need to be within a certain range. Because yeah, if they have too much pressure going through it, they have too little pressure going through it, it's like, oh no, our house is falling down. And it closes in on itself.
Yeah.
So very, very tight pressure management is
hmm
needed for your cabbage patients, which is why they're supposed to be in the ICU.
Yep.
Um, post-op day 0, day 1, day 2, something like that. They're supposed to be there in the ICU after because they need very careful monitoring. There's a lot that can happen afterwards, but
The- yeah. Just like Michelle said, if the hypertension is too high, you can burst the graft. If it's too low, it's not getting enough perfusion, and then the graft, the little vessel dies. So you need to have good management so the graft is properly perfused and you're able to get everything going. Here another key point would be the patient must be on this is a medication. What type of med class? Yes. So this is kind of like a situation where they're like, oh, like the reason they want to be on anticoagulants is because you want to make sure that cabbage does not get clogged immediately after you place it. Yeah, so anticoagulants and antiplatelet medication. So
I
uh
like the fact that you mentioned specifically dual antiplatelets. So
mhm,
Plavix and aspirin a lot of
aspirin.
time.
Yep, exactly. Perfect. So probably like a Plavix, aspirin,
Yes.
ASA. Yeah, but there's a lot of there's a lot of stuff that gets listed here, and a lot of it is a little extra, if I'm being completely honest.
If I remember correctly, I believe they say like technically for a year or two, but they should really be on it long term in general, especially because a lot of them have other risk factors. So typically, like, how do I say? If they were just in a perfect world, for some reason, just getting a cabbage, then it would just be like a shorter term thing, but most of the time they're going to be on it for life.
Mhm.
Dual antiplatelet is not specifically for cabbage as well. You'll see dual antiplatelet in a couple other things as well, but just
Like
know it's
a
not very like
stroke.
yeah. Basically anything where it's like really high risk of the clot. So like post MI, sure. Post cabbage, sure. Um core measure, ooh. I don't know my core measures if I'm being honest with you. What are the core measures for that? Did we get core measures?
I don't think so.
Mm. We got it for heart failure, that's it.
Yeah.
We didn't get our stuff, we didn't have
I
core
believe
measure
I
for mine.
believe post-MI will probably, yeah, probably be on dual antiplatelets too. A statin, yeah. But this is like kind of like the main focus here. But yeah, they'll be on multiple medication. I just wanted to really highlight the anticoagulant part just to keep the graft good. But yeah, someone that needs to have a cabbage will probably be on a statin, probably some other medications, beta blockers, ACE inhibitors. Yeah. And all of that is kind of review as well. Speaking of review, the next part is pretty much all review. That's your congestive heart failure. So if there's no is there any questions on this so far? Like everything we've talked about so far. So CAD, um, general ACS. So what do you do with your good old 220? Cath lab, types of labs, types of assessments, your PCI. What do you do before? What do you do after? The general thing that's going to occur during the procedure. What's a stress test? What's it for? What do you assess? Cabbage. What is a cabbage? What is it good for? What are you worried about with the cabbage? And just making sure that you don't clot it up, ruin the graft. You don't have hypertension, ruin the graft. Hypotension, ruin the graft. Because lastly, we're going to go over congestive heart failure. This is again review. The heart cannot pump effectively. You end up having fluid and electrolyte issues, edema of some kind, either pulmonary edema or your peripheral edema. She does mention like, you do have your different types of heart failure, your systolic versus your diastolic heart failure. Um, your diastolic heart failure would be that preserved ejection fraction heart failure. So you can have heart failure, but your echocardiogram tells you that your ejection fraction's within normal limits. Yeah. Yeah. So your left L for lungs, because the pulmonary edema builds up, that fluid will back up into the lungs. So this is the more of the pulmonary edema. But keep in mind that conversely, I wouldn't say paradoxically, but a lot of your lung conditions lead to right-sided heart failure, like your um, COPD. Um, what was that other one that we talked about that could lead to heart failure? Uh,
Sorry, I was comparing the PowerPoint that they have to ours, and it
oh
says
yeah.
that it was revised in July. So it was revised after our class.
Oh yeah, there was like very minor. I went through actually compared our PowerPoints. That she
Mm.
added like one or two extra slides
Oh,
that were slides that we were given in
wow.
class. But yeah, a lot of the lung conditions can lead to the right-sided heart failure, which is why it used to be called just the cor pulmonale. And the reason why left-sided heart failure leads to right-sided heart failure is because this can cause pulmonary edema. So that's where there's where that connection comes in. But typically, just think of when it comes to complications, L for lungs. So
Yeah.
pulmonary edema, right-sided heart failure, peripheral edema. Let me see what else might be important to keep in mind. Yeah, knowing the anatomy can help a lot. So,
Blood flow through the heart. Yeah.
yeah. So what do we got for here? So some other things, shortness of breath, lung sounds. What does the pulmonary edema sound like? You probably will hear some crackles. Will they be throughout the whole lungs? Will they be just in the bases? Will it be coarse crackles? All that stuff is things to keep in mind. Are you having productive coughing or non-productive coughing actually? Well, that's the early, I suppose. And then later on, it might um, have, yeah. If you have pulmonary edema, you get the bloody one. Dyspnea, yes. Shortness of
Orthopnea.
breath. Orthopnea, dyspnea. Something else. Again, if you're having pulmonary edema, you're having uh, decreased oxygenation, so maybe hypoxia, that maybe you can have acute confusion or something, fatigue, weakness, dizziness, maybe some chest pain from lack of perfusion. So maybe some late signs can include altered level of consciousness. Um, yeah, probably just kind of keep it more simple. While you're right-sided, heart failure, pretty much, yeah. Yeah, the frothy pink sputum, that can be also like if you have like um oops, frothy pink sputum. Like another late sign. Your right-sided heart failure though, that will be um oh, I think yeah, that's what it was. The pulmonary embolism can lead to the pulmonary hypertension, which can then lead to right-sided heart failure. But here, yeah, peripheral edema, so everything that's not the lungs essentially. So JVD, you'll have you can have ascites late term and then hepatomegaly. Basically everywhere that's not the lungs. It builds up in
Everywhere.
everywhere. Yeah. So that's where you could have ascites, you can have hepatomegaly,
Splenomegaly.
splenomegaly, in which case you have other symptoms that you might have hepatomegaly, splenomegaly, you might have the chronic pancytopenia potentially. Not guaranteed, but you can just from the big big spleen taking more stuff in. Keep in mind if things are pitting or not. Yeah, that's a common like test question or Kaplan question where it's like, oh, the patient's complaining that their ring is tighter than usual. Yeah, you can have extra diuresis, the nocturia, that could be a sign. Yep,
Oliguria during the day, nocturia at night.
yep. It's like a yeah, something she directly mentioned.
Random fun fact, why do they get nocturia at night? Yeah, lying down, so it's increasing your, was it your kidney perfusion? Something like that.
Yeah.
Food mobilized during rest.
Do you need to know that? No, not
No.
really. Not really.
That's why I was like, fun fact.
Yeah, just a fun fact.
It was okay. Sorry.
Oh
Oh,
no, no, it's just a fun fact from Miss Salazar.
shally shy.
And you should probably think about like stuff like weight and stuff like that. In terms of management, so what are some management? Yeah. I still know fun facts that are never Aw. I hate when that happens though. It's like, oh, they told me, oh, she said the spirit. Like, sometimes, we do say like you do want to pay attention to stuff that's in class, but sometimes the teacher is just like being a nerd and like that stuff's not on the test and you're like, oh dude, I know this random fun fact, but then it's not actually tested. I don't know. Stuff
Mm.
happens. But yeah, so and this is kind of just in this case just be like very general. What are some things that would be management. You can say either non-farm or farm. I'll just put it in the right place. But what's some things that are important to keep in mind for management?
High
I
fat or low
I do
sodium
like that, yeah.
diuretics.
When in doubt, and when in doubt, it's probably high Fowlers or Fowlers. You want some diuretics for sure. So diuretics, you have the little like mnemonic A B C D D D, I believe it was. So yeah, we have the ACE inhibitors,
Solid.
the ARBs, we have the beta
Yeah.
blockers, the calcium channel blockers,
CCB.
we have diuretics. We mentioned that. What else is? Let's see. See what everyone else mentioned. Okay. Ooh, yeah, I love that. I love the low sodium diet. As in, like, I love that you said that, not that I like having a low sodium diet.
I would just put me out of my
Turn off
misery.
the breath.
Fluid restriction.
Beautiful. I love that. Fluid restriction. The Arnie's, yeah, that's another one. Restriction. Daily weights, I love that. O2 PRN, I like that a lot. Fluid restriction. Yeah, I like that. I like you guys know your stuff when it comes to heart failure, so that's great. The last two for the D's would just be digoxin and dilator, so like vasodilator, like your NTG and stuff. That's kind of how that goes. So we can quickly just let me see if there's anything else here I would include. We talked about weight management, fluid restriction, I's and O's, urine output. So that would be like weights, anticoags. Let's see. I mean, technically, elevate the legs. To keep, um, let's see, smoking cessation, maybe one that could be put in. You're always worried about like their renal function, so maybe uh I don't know if you want to elevate the legs. I don't really think you
For heart failure?
yeah. I don't think it's like there's one way or the other for
I
that.
was gonna say, I don't think it's inherently contraindicated.
Yeah, I don't think it's necessarily
Yeah, decreased venous return,
yeah.
decreased workload on heart.
No, yeah. I mean, I don't think it's necessarily a bad thing. If they have edema, I like to put pillow under their legs and stuff too, because you want to protect their skin because their skin's more sensitive and more sensitive
Like
to
a
skin
tendon.
breakdown. Um, let's see. Mm. Probably because his edema started going. It's like, oh, let me pop this up and I'll pop this up. But I think when it comes to yeah, it seems like you guys really got this down. But I just want to go through this real quick. So with ACE inhibitors, I think the pillows are needed for that, right? Yeah, just put pillows. Do like that. So when it comes to ACE inhibitors and ARBs, what are you? So imagine this is your clinical professor. They tell you, okay, what's this med? What's this med effect? What is it safe to give? What are you assessing before you give this med? Yes, so it's going to lower BP. Anything else you want to assess? Yes, it's going to increase your potassium. Why does it increase your potassium? Because of the pathophysiology behind your aldosterone. Yeah. And if you've ever wondered why it can cause a cough, it's because if you remember your RAS pathway, the lungs are actually involved. Your lungs actually convert angiotensin 1 into angiotensin 2. So that's why the ACE inhibitors can cause a cough, while the ARBs, which just block aldosterone, they don't bother with that little pathway. They don't affect the lungs and they don't cause a dry cough. So that's a fun fact. Snapple top fact. Um, Something else to keep in mind though, let's say you get this question. Let's say the patient has lisinopril, okay, and they report to you that they started having a cough. What's going on in your brain cells right now when you hear that? So patient has lisinopril for heart failure, and they said, okay, I'm starting to have a cough right now. Okay. Do you like the information I gave, or do you think you need more information? You guys kind of went into immediately switching to ARBs.
Oh, ow, ow, ow.
Right. So let's basically what I was trying to get at was don't automatically assume that it might be a side effect. It could be that
A
they're
girl's
get
drowning.
yeah, it could be they're getting pulmonary edema. So are they have what kind of cough are they having? Is it a dry cough? Is it a little wet cough? Are they having crackles, coarse crackles throughout their lungs? Is it a lisinopril side effect, or is it actually maybe heart failure exacerbation? So just kind of things to keep in mind to not get tricked out by some questions. I think that's actually a question from your Kaplan book, actually, like in the book somewhere. I think that's a question. Yeah, so just be careful with that. Um yeah, because I think I got by that, so I'm making sure you guys don't get by it. Get. I'm making sure you guys yeah,
Don't get got.
don't get got. Yes, that's another potential side effects to angioedema. All right, so then let's move on to the ACE is dry. Usually, yes, a dry nagging cough. Yeah, but like let's say in that question, all I said was cough. Then you want to assess a bit more. You don't want to just be like, okay, you're having a cough. Yeah, it must be your lisinopril. Yes. Yes, exactly. So in that scenario, you don't just assume that it's gonna be a lisinopril complication. You want to see if it might just be like or your heart exacerbation happening. So that's where they might try to trick you because that's like a easy mistake to make. So that's where they might get you. All right. So what about beta blockers? Your teacher says, what are you monitoring before you give this? Is this safe to give? All right. So it's gonna be lowering your heart rate and yes, your blood pressure. So it's gonna lower your blood pressure as well. Um, anything else that might come up? Yeah. So when you have there are some beta blockers that are not cardioselective. So something like propranolol or carvedilol, they might affect your can affect those with respiratory disorders if not cardioselective. Yep, met and ate. All right, perfect. Now calcium channel blockers, it gets a little bit tricky because some of them are dipines and some of them you have your like your diltiazem or verapamil, which are like different names, but they fall in their slightly different. But typically speaking, the MA close to your heart. Oh, that works.
Metoprolol.
What's the MA stand for? Ma close to your heart.
Metoprolol.
Yeah, but what's like the mama close to your heart? Oh, I get it. Ma close to your heart. I see.
Mother.
It's like I was gonna. Well, I have like the one where it's like you heart her. You heart her because you met her and she ate because she slayed. I don't know. Yeah, but yeah, you have your calcium channel blockers. In general, you're gonna worry about always, no matter which type it is, you're gonna worry about your blood pressure. So this one's gonna lower the blood pressure. Both are gonna lower the blood pressure, but depending on what type it is, it might affect the heart rate more than the other. So the dipines will typically only affect the blood pressure, while your diltiazem verapamil can also lower the heart rate. So things to keep in mind. I think because I know that's definitely like a thing I learned in farm and then also in preceptorship we gave amlodipine and the computer didn't have me fill out the heart rate. We just took the blood pressure. We still kept the heart rate in mind, but the main thing to look out for was the blood pressure for the amlodipine. While like the diltiazem, you do for sure worry about the heart rate on that one. So that's just kind of the general idea. But in general, just kind of keep in mind, especially because calcium channel blockers is not going to be your primary, like it's not going to be your first line. It's also not going to be a monotherapy. They will most likely be on an ACE inhibitor and like a diuretic or a beta blocker before they get put on a calcium channel blocker. But then your diuretics, you have your furosemide. What's the other word for furosemide? Yeah, it's the Lasix, which is a loop diuretic. And then what does that mean to be a loop diuretic? Or what? Don't give me the patho. Just kind of like what does it affect? All right, cool. So we're gonna lower the blood pressure. We're going to lower the potassium. Cool. And you're gonna want to assess like urine output. Perfect. Yeah, the loop of Henle. Do you need to know that? Not really. But yeah, it's gonna increase your urine output. So it's gonna increase urine output, or it should. Sometimes they, just to tickle the little kidneys or whatever. Nice to know, but not need to know. Yeah, exactly. It's a little fun fact. Other diuretic, so this one, you would call this one a potassium wasting. Oh yeah, Bumex. Bumex is an even stronger version of lace, like a stronger loop diuretic. There's yes, aldactone, aka spironolactone. Spironolactone. So that's aldactone. And this one is gonna be, yep. Yeah, I remember seeing that the Bumex is 40 times stronger than the furosemide. This one's potassium sparing. So this one's gonna lower the blood pressure. But you still want to assess K for hyperkalemia. Because you wanna, especially because like if they're on a diuretic plus like a lisinopril, this one's gonna increase, and this one would end up uh um potentially building it up. Lower blood pressure. This is a potassium sparing. And then mention the thiazides. The thiazides, they function on so an example of this one. So these are just medications that end in thiazide. These affect a different part of the kidneys, but don't worry about it. The main point is it pretty much is the same. You can pretty much copy paste all your loop diuretic stuff on here. Example of this one would be your hydrochlorothiazide, for example. But for the most part, it's pretty much your spironolactone that you need to know it's potassium sparing, and then the other ones that you need to know that yeah, that's also a thing, is that I believe your furosemide is is the strongest overall, other than like the Bumex, which is like a stronger version of Lasix. Your spironolactone is going to be potassium sparing, but it's also less effective. Yeah, actually, I think you're right, actually, on that. I think the thiazide is the weakest of them all. These two are definitely weaker than the Lasix, and then the Bumex is stronger than the Lasix. Hmm. I guess depends on. I see way more Lasix than I'd see any of the other ones. I think I've seen spironolactone on one person only. I usually see Lasix on everyone. Yeah, I feel like I only see Lasix. But I guess by the time they get there, they're like they already they've been got started on that thing like a few years ago. Um, yeah, that can be a thing as well. Alrighty. Digoxin, before you give digoxin, what are you worried about? Your heart rate. So that's going to be, what's it doing to the heart rate? I like it. So lowers the heart rate. And yes, you're going to need to assess the ditch level. Anything else you want to assess when it comes to worrying about toxicity?
Potass.
Wasn't asking you.
Well, people already said it.
Yeah, you're going to assess for potassium as well. The reason why is because hypokalemia can increase the um it's like toxicity. How would you say it? Like the not I would like the efficacy of the ditch, so it makes it more likely for toxicity. Yes, exactly. So now let's see when it comes to that, what is your signs and symptoms of toxicity? I like it.
Picasso.
The nausea, vomiting,
Visual changes.
exactly, blurred vision. So I think the blue green halos are like such a
Green
dead
yellow.
giveaway that a lot of tests will probably not include that just to mess with you.
Green yellow.
Yeah. That what did I say?
Blue green.
Oh, I'm colorblind, guys.
Ah!
Blue green. Yeah, the green yellow halos, it's like a pretty dead giveaway on like the question, so they might just include nausea, vomiting, blurred vision, and you have to use your context clues instead. But this is pretty much like the main ones that you'll probably see on questions in terms of signs and symptoms. I'm sure there's other ones. And then the vasodilators, we talked about the nitroglycerin example. Nitroglycerin, there's a few other ones, but that's like going to be like the main one to think about. Hydralazine can be one. Um, yeah, hydralazine.
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 It's okay. We know what you meant.
Yeah.
I felt that when I can't spell worth it. I can't spell for anything. Horrible.
Yes. So these are gonna be just lowering your blood pressure, and you're definitely gonna want to watch out for bottoming in them out. Dizziness, headache, Milrinone. That's going to be something that's going to be a positive inotrope. So similar idea to the digoxin where it strengthens contractions, but it's actually going to increase the heart rate instead of lowering it.
You mean blood pressure?
Is that what I meant?
Milrinone.
I
I've
think
seen Milrinone used a lot, if I remember correctly, for blood pressure.
I think it does have an effect on it, but it will increase your heart rate, I
Oh, I'm
think, as
thinking
well.
of something else.
No, it does the opposite. It actually decreases your blood pressure, but it
Oh, well,
increases your
I'm
heart rate.
thinking something else. My
I
bad.
th I th Yeah, the butamine. Yes.
My
The,
bad, Chief.
that one's also a positive inotrope that will increase your heart rate. Which one were you thinking of, Kaylin? That will increase your. I think you're thinking of. And I think I know what you're talking about. I forgot the name of it, but it's like the one that's used for increased blood pressure, right?
See, it's used to increase. It's oh God, what's the other M?
Yeah,
Not
that's right. It starts
Milrinone.
with an M. I know what you're thinking, but I can't.
Meperidine,
Yeah. Yeah.
right? Or am I tripping out? I'm a fact check myself. Give me a
Yeah,
second.
I'm interested. I forgot. Not amiodarone. That's
Oh.
for dysrhythmias. Yeah,
Okay.
meparidine's an opioid. You're thinking metodrine, metodrine.
I know.
You're thinking of metodrine.
Thank you. Thank you. What a dream. Thank you, Jesus
See, and this
Christ.
is why you gotta make sure that you're looking at the medication as you're
Oh
pulling it
my
out
God. Because all of them
because
sounded so similar in my head right now.
yeah,
So middle,
I'm
middle
trying to think of the ones I always confuse in my brain. I think Demerol and Toradol. Man, my brain does not like those two words. My brain confuses them. Amlodipine and amiodarone. My brain does not like those.
What the method?
Not really, Ryan. Methergine,
Us helping with
nah.
bleeding.
Yeah. Oh no, midodrine. That's what she was referring to.
See,
Midodrine.
all of these M ones sound so
I know.
familiar.
I know.
So
Yeah,
specific.
clonidine as well. I
God.
had a renal patient that had like six antihypertensives. They were like okay, they had PO hydralazine, they had clonidine, they had a beta blocker camera. I think carvedilol they had lisinopril, furosemide. They got like everything. I know. It's like they want us to make mistakes. It's true. How would they fix that though? They just wouldn't. They start making like medication names that start with like Z or X, so you don't get confused. Were they? Oh, maybe. That's why you need to get you some
About to get
insurance,
us. Oh my god.
bruh. Oh,
Keeping lawyers employed.
I'm like, really? I was like, really? No, that doesn't make sense.
McDonald's.
McDonald's chicken nugget. Other than that, it's just kind of like the patient education. What is on the exam?
McDonald's chicken nugget?
McDonald's chicken nugget.
McDonald's chicken nugget.
Honestly, yeah. Here is just kind of I'm just gonna copy paste it. The patient education that we got from 220. Teach the patient to begin walking slowly, at least 3 times a
Odds.
week. Encourage them to keep a diary of symptoms and what they were doing at the time. Report rapid weight gain, decreased activity intolerance, excessive awakening to urinate, developing dyspnea and angina at rest, increased edema, avoid cans, cough medication, antacids, NSAIDs. And because I had mods. So I remember, okay, in 240, she was like, "All right, guys, mods," and no, everyone's like, "What? I don't remember mods."
I remember
And
that. I
so I
remember that
guess
happening.
she wants you to know mods. This was in 240 though. She was like, "Guys, what's mods?" And we're like, "What?" Not one person in our class knew what mods was. I remember hearing, I'm like, I know what that sounds familiar, but like I didn't actually know what it was. So here's mods from the book. So
Good.
here it says medications, take them as prescribed. Do not run out of your meds. You should probably know what the purpose of the meds are and your side effects. Um, some other examples, activity, be active, but don't overdo it. Weight yourself, your diet, so that's sodium intake restriction. Let's see, diet. I'm blanking on the S. And symptoms, worsening symptoms. Basically, if there's an acute change, do something about it. I mean, this picture should help. It's right, it's all there. Just kind of again, don't hard memorize it, but you can kind of get the general idea. In general, when it comes to this stuff, you don't have to hard memorize it, but like if you see it on a test, you're like, this makes sense. I do believe that they should know their signs and symptoms of their meds. I do think it makes sense that they would notify the MD if their symptoms get worse. Um, Stuff like that. So a lot of review here. I think the key aspect is just knowing your type of medication. So another thing, I guess, is let's give examples for these meds. So what's an example of an ACE inhibitor? Lisinopril. What's an example of an ARB? E yeah. So lisinopril. Cestril. Sheesh. That's gonna be your main prill. Yeah, let's give you the just in case of an ARB. Your common one is losartan. I don't know what the brand name for that one is. Your beta blockers, what do they end up in? Low pressor. I think low pressor is metoprolol, right? Or am I trolling?
I don't know my brands. Forgive me. Oh, she said ope.
Oop. And oop. Yeah, metoprolol is
But what is losartan?
So example, yes, you have atenolol. I have never in my life seen tenneform. That's a crazy word.
She said that's
Carvedilol. I think that's what's the brand name for carvedilol? Coreg, yes.
Corey.
Coreg in the house. Coreg in the
Propranolol,
house.
Inderol with a A. That's okay. I was like, that's the one I always misspelled, and that's why I was like, wait a minute, I know this one.
Coreg.
Corey.
And then who else? We said we got oh cool. Someone has another prill, Alanopril,
Enalapril.
which is Vasotec.
Vasotech. That sounds so bougie.
It does.
Hey guys, I'm
Kozar.
on Vasotech.
That, that sounds bougie.
Kozar!
That sounds like a Russian czar.
Shut. Bruh.
I'm just saying it sounds cool. Upper panel. I, re- ugh, Kaylin showed me like a meme where it's like ICU nurses and patient having anything wrong with them, slap propanolol. Boom. Oh no, it was
No.
propofol.
Propofol.
Propofol. My bad. See, that's
Mm-mm.
another
Don't slap them with propofol.
No, propofol. My brain does not like propranolol and propofol. It keeps
See, that
mixing
was
them
me
up.
with the M's earlier.
Yeah,
Scary
and
stuff.
yeah. And this is why you check your meds.
This is why you triple check your meds.
Yeah, literally. I spell it Enderal. Enderal.
Enroll.
It's
Let's
true.
go.
So true. The peen. Amlodipine.
The student.
Norvasc. Yeah.
Oh. Oh God. I'm running on very little sleep. Forgive me.
Talked about this. We got that. Hydrochlorothiazide is an example. They will end in thiazide. You don't got to worry about that one. Digoxin. What's the brand name for that one? Did No, I think it's just digoxin, right?
Lanoxin.
Lanoxin. And you guys will know. You guys will know. You just yeah. What's the antidote? Digibind.
Digibind, because it
Sounds
binds to the digoxin.
yeah. The Digibind. Sounds like something from Digimon. Digibind.
It kind of does. Uh,
Nitroglycerin, hydralazine. I think your guys are good on all that. I think you guys are solid. I wish you guys good luck on the test. I'll pray for you.
oh,
Um, I'm just kidding. You guys will do fine. Let us know how it goes though, because you know, out of curiosity. Yeah, yeah.
Holy
Yeah.
Spirit, activate.
It
Holy.
was most people's worst quiz.
It was it was mine. I think this one was actually very good for you.
This was my best quiz for some reason.
If I had to take it again, I think I would cry. I oh, I think I would do better because I
I'd do
over
better because we. Oh, sorry. Go ahead. I don't want to interrupt you.
Kaka. I definitely overthought a lot of stuff. So for example, like the oxygen thing earlier, that's why I kept mentioning it. Like, please ask her if she wants you to put oxygen on people because I tripped myself out because I remember them saying something like, "Oh, like, oxygen that's not really indicated for anyone like that their oxygen isn't low," but I guess based off of what she told you guys, she would like you to put oxygen on people.
Yeah.
Yeah, it's not inherently best practice anymore, but just based off of how she was saying with who was it, Ashley? I think it was Ashley
Ashley
earlier that
said it. Yeah.
is Ashley not here anymore?
Uh,
She's not.
probably went to sleep or something.
Oh, I felt that.
When do you guys have class tomorrow, by the way?
8.
Perfect. You guys can make it to the mental health day. Oh yeah.
Oh, you didn't chill it.
Oh yeah. Mental health day tomorrow, 11 to 12:30. Come grab
Put
pizza.
the link. Put the
Pizza.
link.
The link. They should have you guys should have it. Let me see the
No, just make it easier. No, just
true.
so like if even if you're just stopping by, because it's still like 12:30, I think.
Yeah.
If you're literally just like doing a drive-by and like getting a slice of pizza, just put your name in. Just so that we kind of know how much stuff to get.
Yeah. I do be agreeing with that statement.
Yeah.
Let me see. Do I have it? I'm sure I have it.
Bruh.
I think it might be on my laptop. But let me just get the image from here. Is it
I
gonna
have
pop?
bruises on my shin and I don't know how.
Yeah. Well, as long basically, yeah, as you guys can make it, come get pizza, maybe win a prize. I
Yay.
do be bringing prizes. I spent $160 on the prizes.
Oh my God.
But I got an email like before like the session started, and it looks like they're gonna give me my money back. So it looks like we're winning.
Wait, is there a badge reel? Do you have
Yes,
one?
there are. There are a bunch of batch reels.
I'm putting my name in. How much money I gotta put into this for a badge reel?
It's free. Everything in the mental health day is free. You come in, free food, free prizes.
I'm gonna take tickets from people. I mean, no, of course I wouldn't do that. No.
Bruh, it's gonna be everyone's gonna think it's rigged.
I know. That's what I said that last semester. I was like, what if people think it's rigged? Because I was like, what if I won something? And then I'd feel really bad.
Yeah, but we have so again, we have food, drinks, games.
Frank.
The prizes we have batch reels, stickers, compression stockings. We have two for those that didn't buy a hat, I have two hats from the customing. So Cerritos hats. We have an Owala, so a 24-ounce Boba Fett Owala. So it's bougie. The Reno was last week. Yeah. I'll give it to you if I have it. So very bougie. Oh, and we're also giving books. I don't think you guys need it, but I guess Owala. Here, Owala.
Oh, walla walla.
Yeah, the recording should have been posted. If it's not, then I believe it is.
It totally does sound like a Star Wars character.
It does.
Walla walla.
Owala, Owala. But yeah, it's a type of
Oh,
bottle all the bougie people in our class have.
I love it because it actually keeps my water cold, and then it's so heavy to the point that if I
Yeah.
need to use it, I can.
Yeah. Here, before you guys, I guess before you leave, I'll post the, I mean, I have the, I'm gonna stop the recording.